I hope everybody's having a great day today. I'm Eric Christensen, pharmacist and host of the Real Life Pharmacology podcast. Today I'm going to cover cyclobenzaprine, which is a classic kind of older medication that has a lot of kind of quirks, side effects, potential concerns that we certainly need to be aware of. So, generic name being cyclobenzaprine, brand name being Flexeril, as you may more commonly hear it referred to as. Its classification, basically a skeletal muscle relaxant. So the way I remember this drug a little bit by its mechanism is to understand that it does have structural similarities to the tricyclic antidepressants. So, it being kind of an older drug and maybe not studied that well, it's not, maybe perfectly understood how the drug has CNS skeletal muscle relaxant properties, but there's some potential impact on motor activity regarding alpha and gamma motor neurons. So again, that along with some of that structural activity with the TCAs, you can think of anticholinergics as some of the potential side effects. So let's talk about those a little bit. So with anticholinergics, I've covered, I think, one or two of them by now, but you can certainly scroll back through and look at the dozens of podcasts already available. But you got to remember spit, CP, and poop. So the patient cannot do these things. So it can cause some dry mouth. You can't spit. You can't see. So it can cause some issues with glaucoma as well as dry eyes and things of that nature. You can't pee, so it can cause urinary retention, particularly troublesome in patients with BPH. And constipation is a big issue as well. Now, in my setting where I typically work with more geriatric patients, and generally, as we get older, we may have more trouble with pain and different things of that nature as well sometimes. This drug is not the greatest, safest drug to use in the elderly. Now, there are a lot of other drugs that aren't the greatest and safest either. NSAIDs, opioids, they all have their challenges and they all have their kind of unique role in certain situations. But because of those anticholinergic properties, cyclobenzaprine definitely remains high on the list of drugs to try to avoid in our elderly patient population there. So I mentioned the can't spit, see, pee, or poop side effects. You've also got to remember that this has CNS depressant type activity. It is sedating, so you got to watch out for it zonking people out. Falls is another potential concern, dizziness, things of that nature. So keep an eye out for that. Now with cyclobenzaprine, again, being related to serotonin type drugs, TCA type drugs, it's going to potentially have some serotonin type activity. So this is a common thing I see in practice in kind of those drug interaction flags that pop up for you. You may see this with sertraline or paroxetine or fluoxetine, some of the SSRIs, which are commonly used for depression. And that interaction that flags is generally going to be due to the risk of serotonin syndrome. Now, it's always something that we need to think about, that we need to monitor for, so just keep an eye out for it. Again, you need to have some clinical reasoning, some clinical common sense. If you're using too small doses of two serotonergic drugs, the likelihood of serotonin is extremely low. If you're using an SNRI and an SSRI inappropriately together, and then you add on cyclobenzaprine and they're all high doses, we increase that risk, certainly, of serotonin syndrome to a much greater extent. So again, remember with cyclobenzaprine, that TCA activity can have some impact on increasing those serotonin levels and serotonin type symptoms. Again, serotonin syndrome, extremely rare, but a pretty serious condition. And I'll talk a little bit more about that in the drug interaction sections there as well. So a couple of disease states. I alluded to one, BPH. So males with an enlarged prostate, they have trouble with urinary retention. That's something to keep in mind with that adverse effect profile. But I also want to mention another reason why it's not the greatest in our elderly patients is it can kind of interfere with dementia, cause more confusion, and potentially medications as well, which I'll kind of talk about that in the drug interactions portion too here. So let's take a quick break from our sponsor. If you'd be willing to go support our sponsor, it'd be incredibly appreciative. meded101.com/store. All sorts of good stuff for pharmacists, med students, nursing students, different books, resources, test prep material from pharmacist certification exams to simply advancing your knowledge as far as clinical pearls, clinical reasoning, medication selection as well. And I've got a free audiobook as well, and the link is on meded101.com/store. If you've never purchased a book from Audible, they do give you your first one free. So it's a great way to try out Audible, and obviously not going to be of any cost to you if you do not want to continue on with the Audible membership system. So meded101.com/store. Appreciate the support. And let's finish up here on drug interactions. So MAOIs, it's a drug class that's seldom used. But if you do see a patient on, phenelzine or something of that nature, you've got to remember that cyclobenzaprine is contraindicated with that class of medications. I mentioned the SSRIs and that risk of serotonin syndrome. Again, extremely rare, something that we need to just pay attention to and be cognizant of if you've got a patient on some serotonin-related drugs. Cyclobenzaprine could add to that risk a little bit. And then other drug interactions I think of with cyclobenzaprine, I think of a lot of drugs that have additive and or opposing effects. So if you've got a patient who's on other sedating type medications, other CNS depressant type medication, other anticholinergic medication, all these drugs can be sedating. The anticholinergics obviously can pile on to the anticholinergic effects from cyclobenzaprine and really give you significant problems that way. So some of the drugs, just to give you some specific examples I think about. So drugs with anticholinergic activity, I'm thinking of urinary anticholinergics, so oxybutynin, tolterodine, a couple of common ones used. Other common ones, older school meds for allergies, those older generation antihistamines. So you got hydroxyzine, you got doxylamine, you've got diphenhydramine or Benadryl. Some common examples there where you can really pile on to the potential anticholinergic adverse effects from cyclobenzaprine if we're using those drugs together. Other CNS depressant, sedating type medications that we could, again, exacerbate, kind of double up on side effects like sedation. Opioids are a good example there. Z drugs, so that's like Ambien and Zolpidem, things like that. Benzodiazepines, again, your Ativans, your Xanaxes, things of that nature. One other drug interaction I did want to mention, I mentioned cyclobenzaprine contributing to some confusion, potentially exacerbating dementia. You've got to remember acetylcholinesterase inhibitors have opposite activity of what cyclobenzaprine would have. So cyclobenzaprine could basically block the effects of a dementia or Alzheimer's type medication like an Aricept or an Exelon, for example. So those drugs can kind of oppose each other. And are we really getting our best bang for our buck in using dementia medications if we're blunting the effects with a drug, an anticholinergic drug like cyclobenzaprine? So I think that's going to sum it up for today. If you like what you hear, go leave us a rating, review on iTunes. Those are greatly appreciated, or wherever you're listening. And of course, check out meded101.com/store. Your financial support there greatly helps us with the podcast and helps keep things going here. So, always got that free resource, reallifepharmacology.com. Free 31-page PDF, top 200 drugs, where I highlight a few really important clinical pearls for each of those drugs in the top 200. So go snag that for free simply by subscribing. You'll get an email link to download that PDF. And I think we're going to leave it at that for today. This will be, I believe, the final podcast episode in 2018. So I thank you for making it an incredible year. Thank you for listening, and hope we can continue to provide some value as we go into 2019, help you get better at medication safety, medication management, and ultimately help our patients, which is what we're all shooting to do for. So thanks for listening. Take care, and hope you have a great Christmas and a great New Year.